Hi guys, good evening, good evening, good evening. Can you all hear me? Can you all see me? Can we start? Right, so आज हम बात करेंगे trauma. So today's objective is on trauma. So we'll discuss every single component of trauma that is there for us. We'll try to analyze every single point about trauma. Hi Mansoor, good evening. Good evening guys, good evening. Welcome, welcome, welcome back to our BLS series. So today we're starting a new series or new session. We finished with thyroid and parathyroid. Hi Elevate, 555, good evening. So today our objective is to talk about trauma. So we'll have an extensive series on trauma. It is going to go on for at least a good 10 to 12 lectures, but we'll cover every single thing, right? Every single thing that is there in the trauma. Whatever we talk in trauma will be from ATLS, that is the Advanced Trauma Life Support, the 10th edition. Whatever is there, we will cover every single point from there. I'll try to give you a backhand on the Bailey's perspective also. So we have the American guidelines and the European guidelines. We'll try to understand and draw a fine line between those two so that we understand it better. Okay. So without wasting any further time, let's kickstart the today's session on trauma. Now, this topic is very close to my heart. I mean, personally, I have invested a lot of time in trauma. That means to understand in trauma management and all that, right? So we have looked a lot into the trauma component, and I'm telling you as a surgeon, one of the best feeling that you have is when you have a patient who's been brought to casualty, and that patient is just losing it, and you come and you do everything possible, and then the outcome changes dramatically, and that patient goes back home and comes back for follow-up. No, that's the best feeling as a surgeon you're gonna have it. So every single patient who I saw in my casualty with grievous injuries where people said it's gonna be tough, our team was good, we were able to intervene, we put our I can't count the hours. No, they're like we don't look on the clock when you're working with a patient, and when the life is on the line. No, you hardly look at the clock. So we had those, yes, like there were mixed bag. I will not lie. I'll be very honest with you. There are mixed bags, but there are days when you felt really good about yourself. You didn't have sleep, you didn't have food, but at the end of the day, you felt satisfied, right? So that's the feeling that you draw in a trauma posting, and when you do your traumas and you become a trauma surgeon, it's a different ball game altogether. Yes, we have been on the other side of the road also, where you feel really sad about it. There are hardly things that you could have done differently, would have changed the outcome. We'll try to learn about that. See, trauma is a ticking time bomb. Every single, that decision that you make, that the microsecond that you have, and you make a right decision in that, the entire spectrum or the outcome changes dramatically. On the same way, if you make that one small mistake, that one microsecond mistake, it goes the other way, right? So in trauma, it's a ticking time bomb. We'll try to understand, analyze every single component, and then we'll try to see that how best we can help our patients, right? So that is why all you have this ATLS bodies and all. No, they have given you an experience of last 100 years from the World War till date. The trauma continues to evolve. We try to understand better. We're trying to do better. We're trying to bring outcomes better. We're trying to every single problem that we had, now we are trying to find solutions. We're trying to improvise on the solutions. We're trying to work on the outcome. So now trauma is no longer managing, it is outcome driven also. Okay? So based on that, so we'll be talking about various components in trauma, and we'll try to understand that how or what best can we do. Now imagine that you are sitting in a trauma center. Just close your eyes and think you're sitting in the most busiest trauma center in the world, and you are the sole responsible person for every single patient that walks out into your door, and the outcome depends upon your intervention. Imagine you're sitting, and then suddenly there's an ambulance that comes. The door of the ambulance opens, and you are rushed to the ambulance, and then you see the patient is completely drenched in blood from top to bottom. Everything is down there. What would be your next immediate step? You see an ambulance come in, you see a door open, you see a patient inside, completely drenched in blood. What is your next immediate step? Now, I know a lot of you are thinking, sir, we'll look for airway. Sir, we'll try to control the circulation. Sir, we'll do this, we'll do that. No. Imagine it in the same context. As you run towards one ambulance, there's another ambulance that comes. You're in the busiest center of trauma. Then there's another ambulance. Now, if you look at the whole scenario, what am I trying to tell you is to look for the resources and its utilization. What is the most important resource in a hospital, right? If you're in a hospital, you're in a trauma center, what is the most important resource? Is it the blood bank? Or is it your radiology component? Is it your CT machines? Or is it the all the equipments that you have, or the infrastructure? What is the most important? Is it the oxygen line? What is the most important resource? My friend, the most important resource is you. You are the most important resource in a hospital. Without you, things won't turn and run, right? So you are the one which is the most important resource, and I don't want to waste my resource. I want to utilize the resource to the best of its ability. So how do we do that? That is why in a trauma system, we have something called as triage. Now we all know triage is basically a color coding system. Triage is basically a color coding system. Now this color coding system, or the color codes to the patients, are given on the basis of, right? Now there's been a lot of if and but in this. Now when you talk about the triage, triage is best done for when there is a mass casualty. We'll talk about that also. So now in terms of how do you categorize people on triage, the first important thing that you will look up on the triage is based upon the resources required. The resources required to manage a patient. To manage a patient versus resources available. Versus resources available for the patient management. That means, let's say you have a patient who has come with a head injury, right? And you don't have a CT in your hospital. You don't have a neurosurgeon in your hospital. So such patients should not be kept in your hospital. You have to refer it to the nearest trauma center where you have all these facilities available. So that is the first thing that you look in a component of triage. Now the second component is on the basis of outcome. It is on the basis of outcome. And the last one, of course, we'll also consider on the basis of severity. In fact, the triage tells you to pick a patient with the best outcome and the worst severity. In that, you have to pick the best one, right? For example, I'll give you an option just to understand all that context. Let's say you have a patient who has presented to you with tension pneumothorax. There's another patient who has an aortic injury with an aorta which has been transected. Now the probability of survival in these two, you have a patient with tension pneumothorax, you have a patient with aortic transaction, both of them are landed to your hospital, you are the only person who are available. It's a mass casualty situation, you are the only doctor available. Two patients are brought to you in front of you, one with tension pneumothorax, another with a transected aorta. Who would you address first? Now if you think in logically, you would say, okay fine, aortic transaction is a more severe case. Let me go and save that patient first. By the time you go to that patient, you try to intervene in that patient, the tension pneumothorax patient is also getting worsened. And the probability of survival in tension pneumothorax is much better if you put a needle, let the air out, and then come back to this patient is much better. No. So in that context, you are wasting the resources in the patient. Yes, there is higher severity, but the outcome is also poor. But whereas in tension pneumothorax, it is of severe nature, but the outcome is also better. So you judge between these two, outcome, severity, both of them which are best. That is how you will choose in terms of your triage. So triage categorization is a color code categorization, but that should be taking these three components into consideration. But the concept is simple. You need to understand, I'm not going to run behind the severity alone. I will see the outcome, which is the most important component, along with the severity. You have to strike the balance. I hope you all understood that. ठीक है? तो याद रखना, ट्रायज में सिर्फ सिवियरिटी आउटकम नहीं देखोगे, दोनों का बैलेंस देखोगे, लेकिन कौन सा ज्यादा बेटर है? आउटकम ज्यादा इंपॉर्टेंट है. अगर दो पेशेंट है, दोनों की जान खतरे में है, तो जो सबसे ज्यादा सर्वाइवल कैपेबिलिटी रखता है उसको पहले जाके इंटरवीन करोगे, देन यू विल गो फॉर योर द अदर सिवियर कंपोनेंट. नाउ वंस यू हैव taken the patient into these considerations, then you have our color coding system. Now according to the color coding system, what are the various colors that I can assign? Okay. So in terms of color coding system, one which is going to be an absolutely essential would be a patient with a red band. Now, if a patient is having a red band, I would simply call it as an emergency. I'll simply call it as an emergency, and it requires an immediate attention. Stop whatever whatever you're doing, run to this patient, right? So this patient requires an immediate attention. So that is your in the context of red. Next that you have is going to be a yellow band. Now, yellow is what we call it as urgent. That means if you do not have any red patient who requires an immediate attention, you can switch to your yellow patient. Then you have the green patient. A green band patient is what we call it as a delayed presentation. So you can go and do a delayed response to this patient, right? So you have the first one, which is most important, is red. Then you have yellow band. Then you have the green band. The green band patient is also known as the orphan child of the casualty. If you have a green band patient, relax, right? You don't need to rush it. If you're really hungry, go sip a coffee, come back. This patient is going nowhere. Nothing is going to happen to this patient. Is an absolutely hemodynamically stable patient. No need to worry. The new one that you can see in terms of ATLS that is going to be introduced is going to be a blue band. Now, blue is what we call it as an expectant. Blue is something what we call it as an expectant. That means, let's say you have, I've given one example, patient came with head injury. Patient came with the head injury and you do not have a CT scan or a neurosurgeon in your hospital, you're referring to that patient. Now, when the patient has been referred and reaches to the other hospital, you do not want to waste time. So on that blue tag, you'll write the department to which it is supposed to be referred so that you do not lose time. And that is done on a blue band, and that is what we call it as expectant. And the last one, which I would never want to see on my patient, is black. Black is what we call it as a broad dead patient or a moribund patient. So this is going to be of least importance. Okay? So this is the color coding system that we are going to follow on a triage. So this is the color coding system that we are going to follow on the triage so that we'll be able to manage our patients better, right? So this is the color coding system on the triage, and we have explained you that how triage is basically done, right? Now, why it is important to do triage is whichever patient requires attention, you should be able to attend immediately. And whichever patient does not require an immediate attention, you can address him later. Now, this is done because we have something called in trauma called as the trimordial distribution of mortality. We have something called as the trimordial distribution of mortality. Now, what is this trimordial distribution of mortality basically means, right? Somebody is asking me a question, sir, what about the breast topic? Guys, there was a misprint that we had in the series. The first series was the thyroid and the parathyroid. The second series is going to be trauma. After the trauma, we'll come back. So we'll do one as a systematic component. So system and then general, then system, then general, so that the balance remains the same. Okay? So don't worry about it. So we'll try to strike both the components, so you don't need to worry about it. Okay? So breast will be done after we're done with trauma. So the next series that is going to be good 12 to 15 lectures from here on would be purely on trauma. It will be trauma-centric lectures. We'll have everything that is there in ATLS, and then we'll switch to breast topic. Okay? So we have something called trimordial distribution of trauma. In the trimordial distribution of trauma, let's say we'll plot a graph against mortality and time. So on a y-axis, I will say the probability of mortality. And on an x-axis, we'll say the time in which it is going to happen. So I'm going to plot a graph between the mortality and time, right? Now, according to trimordial distribution, you will see the maximum mortality occurs at the time of trauma. The second peak comes within 1 hour, and the third peak comes within days. The third peak comes is going to come within the days and weeks to come back, right? So 3 peaks at which the death can happen. The maximum peak, or can say the maximum mortality, occurs at the time of trauma. Now the second peak comes, this is the second peak. The second peak of mortality is seen, if you look at the time frame, this is within 1 hour of trauma. Within 1 hour of trauma. So the second peak is within 1 hour of trauma. That is why we say that in trauma, the first 1 hour, we say the first 1 hour is what we call it as the golden hour of trauma. So this is what we call it, this window that we have shaded, this is what we call it as the golden hour of trauma. This is what we call it as the golden hour of trauma. This is what we call it as the golden hour of trauma. Now why it is very specifically said as the golden hour of trauma? ठीक है? कौन है? शगुत्फा खनम, क्या हो गया बेटा? सर आप सर्जरी और छोड़ाते हो फिर भी हम फेल हो गए. अरे यार ऐसे कैसे फेल हो गए? एमसीक्यू में गलत होता है बहुत. See guys, okay, when you're talking about theory and when you're talking about MCQs, ये ना थोड़े से दो अलग गेम्स हैं. Theory is all about understanding, MCQ is all about interpretation. ठीक है, जो समझ में आया उसको अप्लाई कैसे करना है वो आपको MCQ टेस्ट करता है. तो MCQ बेस्ड एग्जाम के लिए ना आपको अपने आप को थोड़ा और प्रिपेयर करना पड़ेगा. सो यू नीड टू प्रैक्टिस MCQs. देखो पढ़ने के लिए मैं आपको ये सब पढ़ा दूंगा, ठीक है, यू विल अंडरस्टैंड, यू विल एंजॉय, यू विल इम्बाइब ऑल्सो. लेकिन जब आती है ना MCQ में, तो वो जो फाइन लाइंस होती है ना, इन बिटवीन दी लाइंस पे सवाल आ जाता है, तो वो प्रैक्टिस से बनेगा. तो उसके लिए कोई टेंशन लेने की जरूरत नहीं है, वो भी करेंगे, कोई डोंट वरी अबाउट इट. ठीक है. हाय गोपाल, गुड इवनिंग. ठीक है, चलो. Yes, so as we are saying, why it is called as the golden hour of trauma, it's a very simple concept that you'll understand, that when the maximum mortality is at the time of trauma, you cannot do anything because boom, blast, done. ठीक है, patient was driving, crashed, dead, you didn't have any time to do anything, so you cannot change the outcome at this point. But this 1 hour, this is the point where a patient can reach to the hospital, or your team can reach to the site of the trauma and then make a difference. So whatever you do in this 1 hour of trauma changes the outcome drastically, and the next one comes because of reperfusion injuries and all that, or MOD, sepsis, all that takes care. That occurs within the weeks to days to comes back. So the third peak that you can see. So this is the third peak of the mortality. The third peak of the mortality is going to occur after few days to weeks. It occurs from few days to weeks. And this peak of mortality can be because of reperfusion injury, sepsis, MODs and all that. But again, this is more or less manageable. Okay? So whatever you do in this 1 hour actually brings a lot of difference and changes the outcome of the patient. So it is our job to intervene in this 1 hour, and that is why it is the most important period of trauma, that is called as the golden hour of trauma, right? The golden hour of trauma is that period where if you intervene with right intent, the outcome of the patient shifts towards the positive side. As simple as that, right? So the patient came, the triage was done, he has come within the 1 hour of injury. Now the game starts. So you have to assess, right? So whenever the patient comes, according to ATLS, that is your Advanced Trauma Life Support, ATLS says that every patient who has trauma must be assessed twice, right? In fact, there are multiple surveys. They'll be, going one after the other, but we'll be dividing into two major surveys that you have to do. One is going to be primary survey, another one is going to be a secondary survey. So we'll do, number one, we'll do something called as a primary survey, and we'll do another one which is called as a secondary survey. So we have to do something called as a primary survey and a secondary survey. So when we talk about the primary and the secondary survey, so what is the goal of the primary survey? Now the goal of the primary survey is pretty defined. It is to rule out any immediate life-threatening injuries. It is to rule out any immediate life-threatening injuries. It is to rule out any immediate life-threatening injury. This is the goal that you have in your primary survey. This is the goal that you have in a primary survey, right? Now, secondary survey is also called as a delayed survey. Secondary survey is also called as a delayed survey. So the goal of the secondary survey is to rule out any potentially life-threatening injury. It is to rule out any potentially life-threatening injury. So in the primary, you have to rule out any immediate life-threatening injury, and in a secondary survey, it is to rule out any potentially life-threatening injuries. So you will be examining head to toe, evaluate for every single wound, laceration, anything, including fractures and all that, so that you can counter it then and there itself. Okay? So there are the two surveys that we'll be doing it, the primary survey and the secondary survey. The goal is very simple. Primary to rule out any immediate life-threatening injuries. Secondary is to rule out any potentially life-threatening injuries, right? Now, in order to work and do our things properly, the primary survey is being distributed on a protocol based approach, and everybody knows it. That is called as the ABCDE protocol, right? Now, before we move further, there is another protocol that is being given. I'm just going to write it here. It is called as the CABCDE. Now, what does the CABCDE means? Whenever a patient comes with trauma and the patient is having an visible external hemorrhage, right? If a patient comes to you with a visible external hemorrhage, then you have to control the hemorrhage first and then go with airway. Even that hemorrhage becomes even more important than securing the airway, right? So that is if the patient comes with exsanguinous hemorrhages. Patient is being presented with a visible external hemorrhage, which is of significant nature. You have to do an external compression, control the hemorrhage, and then move forward. To give you that as a significance, the protocol is given as CABCDE. Now in this, A stands for, everybody knows it, A stands for airway. It is airway with cervical spine stabilization. You have airway with cervical spine stabilization. B stands for breathing and ventilation. B stands for breathing and ventilation. C stands for circulation with hemorrhagic control. C is your circulation with hemorrhagic control. Circulation with hemorrhagic control. D stands for disability limitation. It is disability limitation. E stands for expose and environmental control. Exposure and the environmental control. So this is the protocol that we are going to follow. That is going to be ABCDE. That is, A is airway with cervical spine stimulation. B is breathing and ventilation. C is circulation with hemorrhagic control. D is your disability limitation. E is your expose and examine. Right? Now, when you look at the entire protocol that we have laid in front of you, starting from ABCDE, when you look at this, you think that first has to be A, then has to be B, then has to be C, then D, then E. No. It is the order which you have to follow if you have a patient with polytrauma and if you have to address. So this is not the sequence which you have to follow. It is the order of preference. When you have a patient polytrauma where the airway is also included and circulation is there, I would address airway first and then circulation. That does not mean I leave. See, in real life, now all these have to be addressed simultaneously. You cannot be pointy and choosy that I will do airway first, then I will do breathing. No. Simultaneously, all these have to go one after the other. You cannot afford to miss any single point. So in real life scenarios, you will see all of them being done simultaneously. You have a multiple people's, it's a team. You're not alone in a trauma center or in a casualty. You will have a team to assist you, so everything will go simultaneously. But to tell you in the order of preference, you need to address airway first, then breathing, then circulation, then respirability, and then expose and examine. Okay? Now, our job is to dissect each individual component and move forward. So I'll be taking up airway with cervical spine stabilization first, right? So our first protocol that we'll be addressing is going to be airway with cervical spine stabilization. So we'll talk about airway with cervical spine stabilization. So we'll talk about airway with cervical spine stabilization. So we'll talk about airway with cervical spine stabilization, right? Now, when you look at, there are two components that we have given here. Number one, we have given airway, and other one is cervical spine stabilization. We'll talk about both. Now, why cervical spine stabilization? It has been found that every patient who has been addressed with a trauma, right, especially in a road traffic accidents, they are known to have cervical spine injuries, right? So currently we say all patients of trauma must have a cervical spine stabilization until unless proven otherwise. So we will consider every patient of trauma, especially road traffic accident, to have a cervical spine injury until unless otherwise proven otherwise. Okay? I repeat again, every patient of road traffic accident must be considered to have a cervical spine injury until unless proven otherwise. Okay? So this is a standard dictum that you will address the patient with cervical spine stabilization, right? So the first thing that you have to do is an airway assessment. We'll do something called as an airway assessment. That means, is the airway fine or is it compromised, right? So airways assessment is to be done, right? Now, the best way that you can assess an airway, it is the ability to communicate and speak. You look at the ability to communicate, and speak without any distress. Without any distress. That means if the patient is able to talk to you, he's able to communicate, he's able to give you all the history without any distress. So I will say airway is normal. So ability to communicate is present, ability to communicate is absent. Ability to communicate is present, then I would say the airway is normal. I am not worried about the airway. There is no compromise in the airway. But if the patient is not able to do so, or you find there is a problem, right, then you can suspect an airway injury. Then you can suspect an airway injury. Now, in the current scenario that we have, according to ATLS, when would you like to secure the airway, right? In a current scenario, when would you like to secure the airway? That is, when you're suspecting an airway injury, when would you like to secure the airway, right? So in a suspected airway injury, it has been advised that you have to secure the airway. So you need to get a definitive airway. So when you suspect an airway injury, you need to get a definitive airway secure. You have to secure the airway. You have to secure the airway. You have to secure the airway, right? Now, when would you suspect the injury, right? So number one, inability to communicate or speak. It is inability to communicate or speak. That is the first sign that you think the patient is going to have an airway injury. Second, if the patient is unconscious. If the patient is unconscious, right? Now, if there is severe facial fractures, presence of severe facial fracture, and if you find there is presence of inspiratory stridor, if there is presence of inspiratory stridor, especially after a inhalational injury, right? Another reason that you can suspect an airway injury, or you have to secure the airway per se, the other two indications that you have, if you're suspecting a cerebral hypoperfusion, if you're suspecting a cerebral hypoperfusion, and if the patient's GCS is less than or equal to 8, right? There are two additional points. There are two additional points that we have told across here. Now, I'll keep it in a very simple context so that it makes easy sense to us. Let's say a patient has come to you in the casualty and you need to know whether the airway is normal or compromised. The first thing you'll do is you'll start talking to the patient. If the patient says, okay, fine, I fell down, I was driving the car, blah, blah, blah. No, airway is fine. You can leave the patient and then, assess the rest of the thing. On the other hand, if the patient is lying on a stretcher, is not able to talk, he's not able to speak, he's in distress, then you would see that, in those contexts, you can suspect an airway injury by looking at these following components. Number one, he's not able to communicate, or he's unconscious, or there is severe facial disfigurement and fractures, or during inspiration there is stridor. That means there is a tracheobronchial injury that is present. On the other hand, if patient is unconscious, you're suspecting there will be cerebral hypoperfusion. Now that can be seen with respect to Cushing's stride or raised intracranial pressure. We'll talk about it as we move forward. And if the GCS is less than or equal to 8, this is actually an indication of prophylactic intubation. If any one of them is present, you should secure the airway. As simple as that, right? So either you're suspecting an airway injury, or there's a cerebral hypoperfusion, or GCS of less than or equal to 8, you will go ahead and secure the airway. This is what we tell you in ATLS. It's a simple norm and a component that you have. But meanwhile, you have to stabilize the cervical spine also. Now, the best method to stabilize the cervical spine, the best method to stabilize is going to apply a hard cervical collar. It is to apply hard cervical collar. It is to apply a hard cervical collar. Right? So the best method to stabilize, you would have seen in those Hollywood movies, no? Any trauma scene, they have this hard, band or a rigid structure that is present around the neck so that the neck becomes immobilized. So basically, it's immobilization of neck that has to be achieved. And the best method to stabilize the cervical spine is to apply a hard cervical collar. As simple as that. Okay? So, we had the patient who came with trauma. We did an assessment of the airway. We stabilized the cervical spine. And meanwhile, we are going to move forward. Okay? Now, what are the methods by which you can secure the airway? What are the methods that you're going to secure the airway? Give me a second. Okay, sorry. Right, so now we are looking at securing the airway. What are the methods, right? When you're suspecting an airway injury, what are the methods to secure the airway, or what are the best way that you can look for the airways, right? Securing the airway basically means to intubate the patient. It is basically to intubate the patient. Now, when you're planning to intubate the patient, there are different methods that you can do, but the two basic methods that you have for intubation is going to be an orotracheal intubation. We have an orotracheal intubation, or you can go ahead with nasotracheal intubation, or a nasotracheal intubation. You can perform an orotracheal intubation or a nasotracheal intubation, that is to be done. Okay? So currently, whenever we talk about in trauma, the preferred route of intubation is going to be an orotracheal intubation because it is a wide open mouth. It's easy to access, so you can put the tube in. Right? Now, in an orotracheal intubation, it is an easy access that you have. There are different components that you have, we'll discuss about it. But then this is what you have to remember, that orotracheal is preferred over nasotracheal intubation. When would you not do a orotracheal intubation, or what are the contraindications for orotracheal intubation? The first contraindication, if there is severe facial fractures. If there is a severe facial fracture. Number two, if there is an inadequate mouth opening. Either there is a severe facial fracture or severely compromised oral opening or mouth opening, you will not be able to intubate the patient, right? So orotracheal intubation fails whenever there is fractures or inadequate mouth opening. There are two contexts. Now, whenever you have such problems, that is why we have this backup of nasotracheal intubation. So whatever are the contraindications for orotracheal intubation becomes the indication for your nasotracheal intubation. So whenever you cannot perform an orotracheal, you have to go ahead with nasotracheal intubation. Is there a contraindication for nasotracheal? Yes, there is a contraindication for nasotracheal whenever there is an anterior skull base fracture. And this anterior skull fracture, if it is associated with cribriform fracture, if it is associated with a cribriform plate fracture, it's a cribriform plate fracture. So anterior skull fracture is associated with a cribriform plate fracture, and this cribriform plate fracture will result in CSF rhinorrhea. Now, whenever there is a CSF rhinorrhea, you cannot do a nasotracheal intubation, right? Normally, it's a thin bony plate at the base of your nose that separates your central nervous system from your nasal cavity. And whenever there is a break, the CSF will start leaking from here. And you try to put the tube and there is no cribriform plate, you will directly go into your central nervous system. You don't want that to happen. So whenever there is presence of CSF rhinorrhea, you would not attempt a nasotracheal intubation. In fact, how do you know that it is an allergic rhinitis or a CSF rhinorrhea? There are two different things that you can do. One is a sniff test. You ask the patient to sniff it back if the patient is conscious. If the patient is able to sniff it back, it is rhinitis. Unable to sniff it back, it is CSF. Or if you can see at the handkerchief test where you have a blot sign or we can see the halo sign that you have blood, then you have clear component around it, that also indicates it is CSF. Or you can do a biochemical test as well. But more or less, if there is suspicious of CSF rhinorrhea, you should not go with nasotracheal intubation. As simple as that, right? So intubating methods, you have these two, that is orotracheal, nasotracheal. If in some component or some day, or as I say that every day is not a Sunday, you tried both orotracheal and nasotracheal and you are unable to intubate. You are unable to intubate. What will you do? So you had a patient who has been brought to the casualty with a compromised airway. You tried your orotracheal intubation, you are not able to intubate. You tried a nasotracheal intubation, you are not able to intubate, you are losing time. This patient, if you don't secure the airway, is going to die in next few minutes. What would you do? If you're unable to intubate or unable to secure the airway, what can you do? So in an emergency setting, what can you do? And as a definitive component, what can you do? So in an emergency, what can you do? And as a definitive procedure, what can you do? Now, whatever you do from here on, actually going to decide whether the patient is going to live or die. It is you who are going to save this patient's life. Now, you tried a orotracheal intubation, it's not happening. You tried a nasotracheal intubation, that is also not happening. Or let's say there's a contraindication for both. Right? Patient had an anterior skull base fracture with severe disfigurement of the face with CSF rhinorrhea. You cannot do orotracheal or nasotracheal. Then you have to secure. On an emergency basis, what am I going to do? On an emergency basis, we are going to perform a needle cricothyroidotomy. We are going to perform a needle cricothyroidotomy, right? So let's say you are working in a casualty and you have the most experienced casualty sister with you on the duty night, but she's too senior for you, right? And she's the dawn of the casualty, right? So she is standing over you, right? And she's seeing you struggle, You want, she knows when to do what, and she's seeing you struggle, and suddenly you say, sister, we need to do a needle cricothyroidotomy. This is great. Okay, where would you put the needle? So first of all, what is the needle that you would use? What is the size of the needle? And second, where would you put the needle? This is the neck that you have. Now, this is what we call it as the hyoid bone, that is right in the center that you have. Then you have the thyroid cartilage. Then you have the cricoid cartilage. And then you have the trachea that starts from here, right? And then you have the membrane between these two, no? So we have the hyothyroid membrane and the thyrocricoid membrane that you have. Okay. Now, this is your hyoid, this is your thyroid, this is your cricoid cartilage. And it's a needle cricothyroidotomy. She's given you a needle and she's asking you to insert the needle so that you can flush the lungs with air. So what is the needle? So needle that I'm going to use is going to be a wide bore needle, that is going to be a 14 gauge needle. Where would you insert? Cricothyroidotomy, between the cricoid and the thyroid cartilage. So this is where I am going to insert the needle. So once I insert this needle between the thyroid and the cricoid cartilage, I have gained the access now. Now after you gain the access, what am I going to do? I am now going to connect it to a high flow oxygen. I'm going to connect it. I'm going to connect to a high flow oxygen. So when I say I'm going to connect it to high flow oxygen, how much amount of oxygen has to be flushed? It is going to be 15 liters per minute. Okay. So you open the valve at 15 liters per minute, and then you flush the oxygen so the patient remains well flushed, right? So the app is not working. Beta, this is on a YouTube, it is not on the app. I hope you're able to see. I don't see any lag across here. Right, so on an emergency basis, this is what we're going to do. We are going to do a needle cricothyroidotomy. Now, this is only going to buy me some time, but as a definitive procedure, what will I do? As a definitive procedure, I have to go and perform an emergency tracheostomy. You can do an emergency tracheostomy can be performed, or you can do a cricothyroidotomy also. Normally, cricothyroidotomy is contraindicated in age less than 12 years. It is contraindicated in age less than 12 years. So in children, we say we'll not do a cricothyroidotomy, we'll do a tracheostomy only, right? The ET tube that you can use for emergency intubation, it is going to be 5 to 7 size tube that we have that can be used to intubate the patient. Okay? On emergency, 5 to 7, children 5, adult 7 is what we use to intubate the patient. Now again, when they say in emergency tracheostomy, what is the incision preferred? Remember, in an emergency tracheostomy, I would prefer the incision to be in a midline vertical fashion. Elective, it is going to be transverse. But again, if you're talking about cricothyroidotomy, it has to be a transverse incision. But in a tracheostomy, if this is the trachea, this is the suprasternal notch that you have, just for the sake of understanding, this is the trachea that is present here. Let's say this happens to be the hyothyroid membrane, this is the thyrocricoid membrane that we have. Normally, we prefer all the way from the thyroid cartilage to suprasternal notch. This is the incision that you will put for your tracheostomy, right? So in order to secure a definitive airway, it is going to be a vertical midline incision. So in emergency tracheostomy, it is going to be a vertical midline incision. A vertical midline neck incision can be placed. Okay? So this is how we are going to secure the airway. By hook or crook, I am going to gain the airway, or else I'm not going to sit quite. Okay? So this is the entire context. So just for the sake of understanding, I'm just going to move it a little bit towards that side. Let's say if this is about securing the airway, you will intubate. Okay? Now, a quick recap on what we have done. So whenever a patient comes, okay, whenever a patient comes with airway, let's say in ATLS protocols, the first one is airway with cervical spine stabilization. How do you suspect an airway injury? The assessment is quite simple. You ask the patient to talk, able to communicate, no problem. Unable to communicate, yes, there's a problem. If the patient is unable to communicate, you look for any of these following components are there. If they are present, there's a compromised airway. Now, in order to intubate, now the maneuver that you follow is going to be a chin lift. We'll do chin lift, jaw thrust, and then intubate. So the standard maneuver that we follow, that chin lift, jaw thrust, and intubate. There are two methods of intubation that you have, the orotracheal and the nasotracheal intubation. Orotracheal is the preferred one, nasotracheal if orotracheal is contraindicated. When can you not do a orotracheal intubation? When there's a severe facial fractures or inadequate mouth opening. I will switch to nasotracheal. When can you not do nasotracheal? When there is presence of your cribriform plate injury or damage which is resulting in CSF rhinorrhea, I cannot do a nasotracheal. Then either ways, orotracheal, nasotracheal, you're not able to intubate, what will you do? You have two components. In emergency, you'll do a needle cricothyroidotomy. In a definitive procedure, you will do a tracheostomy. But meanwhile, we forgot that we have another guy. What is another guy? I said there is cervical spine stabilization. So everything has been done. Let's say this is how you secure the airway. If the airway is normal, you have to rule out the cervical spine injury. How would you rule out a cervical spine injury? Now, we do something called as the C-spine assessment. Now, in a C-spine assessment, you need to know whether the patient is having a cervical spine injury or not. Right? Our objective is to look for, is there any cervical spine injury is present or not. Now, how would you do so? Now, the best method to do this is going to be to look for the component, and that is given by nexus. We have something called as the nexus criteria. Now, what is this nexus criteria? Nexus full form is National Emergency. It is a National Emergency X-ray Utilization Study. It is a National Emergency X-ray Utilization Study. Right? Now, according to the nexus criteria, it says every patient of trauma must get a C-spine X-ray done. Now, on the basis of C-spine X-ray, we will see whether there is presence of injury or there is absence. So, there is evidence of C-spine injury. There is evidence of C-spine injury is present. Then I'm going to manage accordingly. So I'll call my friend who's a neurosurgeon and I'll hand over the case to them so that they can take care of the C-spine injury which is going to be there. Now, if there is on an X-ray, if there is no evidence of C-spine injury, on an X-ray, if there is no evidence of C-spine injury, does that really mean that there is no C-spine injury? No, don't do that, right? Now, not all cervical spine injuries can be traced on an X-ray. So what Nexus tells you is, on X-ray, if there is an evidence of C-spine injury, yes, there is a cervical spine injury, but on X-ray, if there is absence of C-spine injury, that does not rule out the C-spine injury. So Nexus says, in order to rule out when the X-ray comes out to be normal, in order to rule out the cervical spine injury, Nexus has given you an extensive criteria. So what is this criteria, right? So we went to Nexus. We said, Nexus, can you please tell us how to rule out the cervical spine injury? Nexus says, don't worry, I'll give you the single most important criteria. I said, what? Nexus says there should be no posterior midline cervical tenderness. There should be no posterior midline cervical tenderness, right? So went to Nexus. I said, Nexus, can you give me a criteria? Nexus says, you have done the X-ray. I said, yes, the X-ray is done. What is there in the X-ray? I said, X-ray is normal. There's no injury only. Nexus is okay. As I told you before, if there is no evidence of injury on X-ray, that does not rule out the injury, right? So what you have to do, take your thumb and gently stroke the midline of the C-spine of the patient. You stroke the midline of the C-spine of the patient. If the patient is giggling and all that, is fine. If the patient is wincing in pain, there's tenderness, you have to suspect a C-spine injury. So first, if there is no posterior midline cervical tenderness, you can rule out the cervical spine injury. As simple as that. I say, Nexus, that's it. Nexus, yeah, enough. You have to read so much. No, you have all 19 subjects. I cannot teach you all surgery and trauma only. You go home and read only this much. It is enough. So as I was about to get out from the Nexus room, suddenly I remembered, Nexus, I have one question. Nexus is what? I was in casualty. No, I found one patient who was completely drunk and intoxicated. He's an alcoholic, right? Now, an alcoholic patient who's completely drunk and he's landed in your casualty and you try to stroke his neck. Do you think he'll respond? The answer is no, right? Nexus is yes. Good point. We'll add that to our criteria. Now, the second criteria is there should be no evidence of intoxication. That is, patient should be in absolute senses so that he can appreciate tenderness, right? I said, okay, great. Nexus, is that enough? Nexus, yeah, it is enough. Go home, relax. I said, Nexus, I have another patient. Nexus says, now what? This time I had a patient who had a road traffic accident and had a head injury. In that, the patient GCS is around 8 or 9. A GCS which is so low, do you think he'll be able to appreciate pain? The answer is no. Nexus, yeah, good point. We'll add that also, right? Nexus says that there should be a normal level of alertness. There should be a normal level of alertness, and there should be no focal neurological deficit. There should be no focal neurological deficit, right? These are the criteria. I said, Nexus, are these enough? I am also not able to recall any more scenarios. I think the scenarios are enough, right? Nexus is, yeah, see, there is only one true scenario, that is, there should be no posterior cervical tenderness. All the other three are adjuvant. I was about to leave Nexus room and suddenly I remembered there's another patient. Nexus, I have one more patient. Nexus is, now what? Nexus, this is the last criteria, no more criteria. I said, okay, fine. Nexus, the criteria is, I had a patient who was sleeping on the footpath, and suddenly, one guy who was drunk and all, and he was driving his sports car, he ran over the patient's leg and the leg is completely been crushed. Now, if a patient is having a severe injury in the lower limb, he's crying and wincing because of the pain in the lower limb, and you try to stroke the neck, do you think you'll be able to appreciate the difference whether he's wincing due to cervical spine tenderness or due to the lower limb? The next is yes, it is also a good criteria. We cannot differentiate. We cannot put it. I said yes, we'll add that also. There should be no painful, distracting injuries. There should be no painful, distracting injuries, right? Before I could say anything, Nexus says, get lost, only these criteria, no more. I will not give you any more, okay? Read, this is more than enough. You try to read extra, you will cause your own problems. This is enough for us. I said, okay, great. So according to Nexus has given us a very clear-cut component. Nexus says that you have to evaluate these following, right? The first one, there should be a normal X-ray. That means on X-ray, there should be no evidence of any injury. I said accepted. Along with that, the adjuvant criteria that the Nexus has given, there should be no posterior midline tenderness. There should be no posterior midline cervical tenderness, right? There should be no evidence of intoxication. There should be a normal level of alertness. There should be no focal neurological deficit and no painful distracting injuries, right? If you have all these accepted, then you can rule out the cervical spine injury. You can say, patient, जा जी ले अपनी जिंदगी आराम से, ठीक है? So this is all about airway, how you're going to manage, assess and stabilize. Congratulations. Today you have learned about airway and you are now able to save a patient with a severe or a compromised airway that is present. Now, if you go to anesthetist, they'll give you all these fancy components that is for airway. Just for the sake of understanding, the first image that is there of the airway, it is nothing but the oropharyngeal airway, right? So it's a mask that you have, you put it inside the mouth and then you rotate it by 180 degrees so that you get into the airway space. So it's a rapid intubation method that you have. This is your oropharyngeal airway. This is your oropharyngeal airway that is present. This is a oropharyngeal airway. This is quite interesting, where you put it directly into the esophagus and you lift it up so that the air goes into the trachea. This is what we call it as the I-gel. This is what we call it as the I-gel, another tube that you can see across here. Now you can see a luminal tube that is present here. This is your laryngeal tube. This is the laryngeal tube that we have. This is the laryngeal mask airway. This is your laryngeal mask, right? So we have the four important ones, that is the oropharyngeal airway, the I-gel, the laryngeal tube, the laryngeal mask, and one that is not commonly used. This is your multi-lumen esophageal tube. It is your multi-lumen esophageal tube. Not very popular. You put it in the esophagus, inflate the cuff, so it spends. You have fenestrations which are present on top. You can see the small holes which are present. Now these fenestrations which are present will flush the air into the trachea, and that's how you get the airway, but not very popular. Okay? So standard tubes are there, but these are the special tubes that you should be knowing it. So there's an oropharyngeal airway, there's an I-gel, there is a laryngeal tube, the laryngeal mask, and your multi-lumen esophageal tube, right? So there are the various tubes by which you can intubate your patient. So this is all for today in trauma that you should know. So we started the traumas lecture today. So we have done the airway. So airway is what is going to be the first component. We learned about triad system. We learned about how do we categorize the patients. We learned about the primary survey component, secondary survey. Then we spoke about how do we assess an airway, manage an airway, and then rule out a cervical spine injury, right? So that is all for today. If you have any questions, any queries, do let me know. You can reach out to me. Yeah, as we all know, Instagram, it is the surgery guy. You have the Instagram, you have the Telegram group by the same name. It is by Dr. Sandeep Seeram Reddy. Any questions, any queries, anything, please feel to reach out on this, right? So with that, thank you so much. Better GCS and all we'll do in disability limitation. So today we did airway. Tomorrow we do breathing and circulation. Then you have the Wednesday will be disability limitation and expose and examine, right? So every day 1 hour, and we'll spend equal amount of time to understand all the concepts, right? So with that, see, trauma is a long series. We are not going to complete in 1 or 2 hours. The trauma will take good 10 to 15 hours. We will spend 10 to 15 hours to explain every single concept in trauma so that you understand it better, right? So with that, thank you so much. Thank you, Kaushik. Thank you, Rohit. Thank you, Bhumika, right? So I think Liaquat is there. All right, thank you. Thank you, Mansoor, right? So signing off for today. If any questions, any queries, feel free to reach out on the Instagram or on the Telegram group that you have. Come back tomorrow. Tomorrow we'll be doing a very important topic that is going to be breathing and circulation. Very, very important components in the ATLS as well. We'll dig more deeper into it so that the concepts are even more clear. With that, thank you so much. Signing off. See you tomorrow at 9 p.m. on YouTube channel. Bye bye. Take care.